Hello and welcome to the Clinical Cases series. Today we're going to be looking at the cases that we were taught about in the first week of the respiratory block. So let's get started with sinusitis. So sinusitis essentially is just inflammation of the lining of the sinuses, which results in symptoms. So the symptoms that you'll expect from a patient are nasal congestion, discharge from the nose, pain and tenderness, fever and occasionally toothache also. Sinusitis can be classified into acute, recurrent and subacute. So an acute form is when there's a new infection which lasts up to 4 weeks. A recurrent form is where you have 4 or more episodes within a year. And a subacute form is where you've got an infection which lasts 4 to 12 weeks. In terms of treatment, we can treat it with decongestants, ibuprofen and saltwater nasal washing. And essentially, understanding the location of the 4 sinuses normally allows you to be aware of how this disease manifests. So it's the lining of these sinuses, so it could be the frontal, the ethmoidal, the sphenoidal, or the largest sinus, the maxillary. We were also taught about epistaxis, which is just another word for nosebleed, and this quite commonly occurs at the Kisselbach's plexus, which is an area in the nose where there's extensive anastomoses of blood vessels, which supply the nasal cavity. Essentially, this is quite a large set of nosebleeds, particularly in children, when they're picking the nose, but also there are local factors which cause it, such as trauma, foreign bodies, and inflammatory reactions. And also you've got systemic factors such as hypertension and infectious diseases. One thing we were not taught about, but it's good to know, is that posterior nosebleeds are more likely to require medical attention, and in some cases blood can come up to the eye through the nasolacrimal duct. So moving on, we learned quite a lot about the larynx, and essentially, in order to understand the nerve lesions to the larynx, you need to understand the innervation in the first place. So the larynx receives both its motor and sensory innervation via branches of the vagus nerve, and the 2 nerves that you need to know about are the recurrent laryngeal nerve and the superior laryngeal nerve. So the recurrent laryngeal nerve provides sensory innervation to the infraglottis, so the lower part of the glottis, and motor innervation to all of the internal muscles of the larynx. So that's all of the internal muscles of the larynx, except the cricothyroid. On the other hand, the superior laryngeal nerve, the internal branch of it provides sensory innervation to the supraglottis, so the upper part of the glottis, and the external branch provides motor innervation to the cricothyroid muscle. So where the cricothyroid doesn't get its innervation from the recurrent laryngeal, it gets it from the superior laryngeal, the external branch of that instead. So in terms of nerve lesions, why is it so common to get a nerve lesion of the larynx? Well, it's because it's quite vulnerable to damage, especially when you're having an operation on your thyroid gland, because it's so proximal in terms of its vasculature. The left recurrent laryngeal nerve may be involved in a bronchial or esophageal carcinoma, or both recurrent laryngeal nerves may be damaged by a malignant involvement of deep cervical lymph nodes. So as you can see, there's quite a few different ways that the laryngeal nerve can be affected or become lesioned by different clinical manifestations of different diseases or surgeries. Also, just be aware of unilateral versus bilateral lesions. So essentially a bilateral lesion is worse, and it can impair your breathing and speech. On the other hand, unilateral, it's still bad because it kind of paralyzes one side of your vocal cords, but usually the other vocal fold is able to compensate. So, moving on, we looked at obstructive sleep apnea. Now, in order to understand OSA, it's important to kind of go back to basics and understand about sleep disorders in general. So sleep disorders can be split into respiratory and non-respiratory. So respiratory sleep disorders are things like OSA, so obstructive sleep apnea. You can also have central sleep apnea and obesity hyperventilation. Non-respiratory sleep disorders include narcolepsy, periodic leg movements, parasomnia such as nightmares and sleepwalking. So sleep apnea in general is a group of related conditions that are characterized by abnormal breathing during sleep, and then from there you can divide them into obstructive or central. So in an obstructive blockage, the airway is partially or completely blocked. So this is basically the failure of the upper airway to maintain adequate patency when the upper airway dilator muscles relax during sleep. On the other hand, it could be central, which is where the patient actually fails to make the effort to breathe, and therefore this is a problem with the brain pattern for sleep. The obstructive form lasts around 20 to 40 seconds, but the central form lasts for around 10 to 30 seconds. And essentially the central one usually occurs intermittently or in cycles. The causes of OSA include old age, brain injuries, decreased muscle tone, or simply structural features that could have been congenital. In terms of diagnosis, they tend to use oximetry or polysomnography. Polysomnography is probably a better way of looking at it because it allows you to characterize the pauses in breathing when sleeping. But oximetry is useful in itself because essentially, if the airway becomes blocked, therefore you're going to have less oxygen inside your body. So if you're measuring the oximetry, the levels of oxygen are going to fall when you're having these periods of sleep apnea. In terms of management, the most effective management that is used at the moment is CPAP, so this is continuous positive airway pressure, which is a mask that patients tend to wear when they go to sleep. I guess it can be quite uncomfortable, but essentially if it's going to allow them to get a good night's sleep, then they're going to do it, if they've been suffering that badly from it in the past. The most common symptoms that a patient will explain to you is that they've had unexplained daytime sleepiness, they've had restless sleep, and it tends to be their partners that make the reference to the fact that they sometimes have loud snoring or periods of silence followed by a big gasp, for example. There are some differences in symptoms as well between adults and children. So adults is mainly focused around that excessive daytime sleepiness, whereas in children it tends to come back to stunted growth or the inability to thrive in terms of growth due to the fact they're not getting enough sleep. Overall, things that are concerning about OSA, particularly if your patient is a truck driver or they operate machinery, because obviously in unexplained daytime sleepiness it can increase the risk of crashes for cars and trucks, or as well obviously it can increase the risk of occupation hazards in terms of if they're operating machinery or anything like that during the day. So just a brief look then at non-respiratory sleep disorders. So you can have narcolepsy, which is more linked to a neurological condition, which is caused by the failure of neurotransmission in neurons in the brain. And the neurons that are relevant are orexin and hypocretin. Usually it arises as damage to this neurotransmission, so it's usually from a viral infection in a person who's got that genetic susceptibility to allow that to happen. So parasomnias are another non-respiratory cause of sleep disorders. So these can be more refinedly diagnosed by REM or non-REM. So REM is where you're acting out dreams during the later part of the night. These dreams can be violent and could be triggered by medication. The usual medication that affects this is those medications that affect paralysis, so things like Parkinson's medication. Alternatively, it could be non-REM, so this is typical sleepwalking or talking that you're experiencing the first half of the night during slow wave sleep. This can be genetic, or it could be triggered by stress or change in environment or alcohol. Also, another cause of sleep disorders, if it's non-respiratory related, are restless leg movements. This is either an actual repetitive leg movement or simply a desire to move the legs, and it usually occurs when the patient's got a deficiency in iron that's affecting the GABA transmission. It can also be made worse by caffeine and certain drugs. This can be quite distressing for patients during the day, but also obviously can disturb sleep at night. Pneumonia, this is an inflammatory condition of the lung affecting the small air sacs, so the alveoli. It's usually caused by either a virus or a bacteria, and the presentation is slightly different, particularly in children. Occasionally it can, however, be caused by medications and conditions such as autoimmune diseases. So a bacterial presentation would be where your fever is greater than 38.5 degrees, the respiratory rate's over 50, and you can observe wheeze, chest recession and abdominal pain. Whereas a viral pneumonia, you'd expect the patients to be usually infants and younger children. You'd expect them to have a wheeze still. The fever, however, would be less than 38.5 degrees. The respiratory rate would be more normal or might just be slightly raised. In terms of risk factors for pneumonia, it could simply be a link to another lung condition such as cystic fibrosis, COPD, asthma. There are other general conditions as well, so diabetes, heart failure, history of smoking, and a poor ability to cough following a stroke. Hospital-acquired pneumonia is another topic that kind of is quite common. In terms of treatment, if a patient is severely ill with pneumonia, they'll be hospitalised and therefore they'll need oxygen therapy. If the pneumonia is bacterial, it can be treated with antibiotics, particularly amoxicillin in quite a big dose for children. But essentially the treatment relies on the underlying cause being found out, whether it's bacterial or viral, to decide the treatment. So there are vaccinations available to prevent certain types of pneumonia. but often prevention simply comes down to hand washing and not smoking. On this chest x-ray here you can see for pneumonia. World Health Organization does define pneumonia as a cough and a difficulty in breathing. It used to be a triad of symptoms, but now they've refined it to just cough and difficult breathing. 2 cases left, so you've got bronchitis and bronchiolitis, and it's important not to get these confused. So bronchitis is an inflammation of the bronchi, which are the large and medium-sized airways in the lungs, and it can be acute or chronic. On the other hand, bronchiolitis is an inflammation of the bronchioles, so these are the smallest air passages of the lungs, and this usually occurs in children that are less than 2 years old. The symptoms are quite similar for both, so coughing, wheezing, shortness of breath, but in bronchitis they'll cough up mucus. So as we've already said, bronchitis can be acute or chronic. So an acute form is where you have a cough for around 3 weeks. Usually it's due to a viral infection, but you can treat this quite easily with paracetamol, rest and NSAIDs. On the other hand, the chronic condition, this is quite a lot more severe. So this is where you have a productive cough lasting 3 months or more per year for more than 2 years. Most of these patients also have COPD, can be quite linked to smoking, and therefore treatment really focuses on bronchodilators, steroids, and the patient being able to stop smoking. In terms of bronchiolitis, we've already mentioned that it's a disease that really does more commonly affect children. So it's really quite common, and it affects 1/3 of children in their first year of life. It's most commonly caused by RSV, which is respiratory syncytial virus, which causes around 70% of the cases of bronchiolitis, and it is more common in the winter. In terms of treatment, it's very much supportive, so support with oxygen, monitor the patient, and give fluid and nutritional management, because sometimes the children who are that young have difficulty feeding as a result of the bronchiolitis. There's no evidence, however, to support antibiotics or surfactant or physiotherapy in terms of helping the treatment of bronchiolitis. Influenza, so this is essentially a flu. So it's an acute respiratory infection caused by the influenza virus, which circulates in all parts of the world. There are 3 types to be aware of. So type A, which can undergo an antigenic shift and drift. Type B, which can undergo the drift only. And type C, which is relatively stable. The incubation period is quite short, so around 2 days, but it can be up to about 5 or 6 days. In terms of signs and symptoms, it's a very sudden onset of fever. So one big difference between a cold and a flu, so influenza, and a cold is that influenza comes on suddenly with a dry cough which is persistent, and a headache and muscle and joint pain. There are vaccinations available to protect you from influenza, and the people that should definitely have the vaccine are these who are in the risk group, including pregnant women, young children, old adults, and healthcare workers. In terms of treatment, usually it's focused around bed rest with lots of fluids, but occasionally the doctor may prescribe an antiviral medication such as Tamiflu. Last thing to look at here, so it's not particularly a clinical case, however it's good to be aware of chest x-rays and how to read them. So a 4-step approach allows you to look at consolidation, interstitium, nodule or mass, and atelectasis. So this diagram kind of shows you nicely what each of those are in terms of a picture view, and up here explains exactly what they are. And this here is a nice diagram which demonstrates the pure anatomy of the chest x-ray, so what you'd see on a completely normal chest x-ray, and therefore how you could link that to what would be going wrong. Down here there's some examples of abnormal chest x-rays, so you've got pneumonia, attention pneumothorax, pleural effusion, and a small cell cancer of the right lung. We're not particularly expected to diagnose from chest x-rays in second year, however it's good to have an idea of what each of these particularly common things present like on a chest x-ray. Particularly pneumonia and cancers, so being able to detect those when you see chest x-rays either in your placement or simply when you're doing your studying. Okay, so that's everything for this video. As always, if you do have any feedback or comments, please either leave them below or let me know personally. You're more than welcome to direct message me. And if you've got any suggestions for future videos, please do let me know. And I hope you found everything useful. Thank you very much.